Hello, welcome and a very good afternoon from the MEDEL headquarters here in Innsbruck. And I'm particularly grateful to also welcome our today's expert, Professor Dr. Hubert Löwenheim. My name is Michael Böckel and I'm the product manager for MEDEL Cochlear implants and electrodes. And today I will be your moderator for the first event in a case series of very interesting MEDEL hearing implant surgeries called SurgeryONLINE. This will be a hybrid event, which means that key opinion leaders in the field of hearing implant surgery will present you one of their cases on the basis of a recorded high-quality surgical video. But everything around that is live and interactive. In this way, you have the opportunity to not only watch an interesting hearing implant case, but to learn from the best and ask the surgeon directly whatever you want to know about this case. For example, indications, candidate selection, about the anatomy, and certainly the surgical technique, hearing and structure preservation, and so on. And of course, they are going to share their clinical pearls and pitfalls with us. Now, I would like to switch over to some participant tips for all of you joining this meeting. So please name yourself, preferably please with the full name, no nicknames if possible. Type also, if possible, your organization and the country you're coming from. Also, to avoid background noise, please mute your microphone if you do not speak. And also, please mute your private phone in the background so that we can have an undisturbed meeting. For a stable internet connection, we also would recommend on your side that you are closing all the background programs, what you might have open on your computer. That would probably ensure a really nice and stable internet connection. And in general, so to participate, we would like you to use the chat and type in your questions there while we are going to present you the surgical video. And we will review these questions after the live narrated video, which will run for around 20 minutes plus. Yeah. And so please type in the questions there for the meantime. And after this video, when we are reviewing these questions, of course, you can also, if you prefer, unmute yourself and ask your question live, of course. And today, so we are going to show you a MEDEL SYNCHRONY 2 cochlear implantation with a Flex 26 electrode performed by Professor Dr. Hubert Löwenheim. And it's now my pleasure to introduce him to you. So he is a professor and the chair of the Department of Otolaryngology, Head and Neck Surgery at the University Medical Center of Tübingen, where they have more than 50 years tradition in otology and neuro-otology. So the clinic covers a catchment area of around 3 million people, and therefore you can imagine they have a rather large patient base. His department has around 5,500 inpatients and about 30,000 outpatients every year. Professor Löwenheim's main clinical interests are in otology, neuro-otology obviously, but also in lateral skull-base surgery. Whereas his research interests lie in the inner ear biology, especially like the regeneration of sensory hair cells, autoprotection, and the fluid regulation in the inner ear. But before I'm going to turn over to Professor Löwenheim, who's going to present you his SYNCHRONY 2 implantation, I hope you give me 2 more minutes to show you what our newest MEDEL cochlear implant, the one we are about to see now, is all about. So the MI1250 SYNCHRONY 2 is our newest member in the SYNCHRONY series implants. And I will show you now some key features of this new designed implant. Obviously, like all implants in the SYNCHRONY series, they feature a 3 Tesla removable diametric magnet. That's what I think most of you already know. But what stands out in the SYNCHRONY 2 is now that it features a central electrode lead exit, also an angled fantail. These 2 features, they are there to make the implant actually side symmetric. So due to the side symmetry, this implant, it's no matter if you implant a left ear or a right ear, it's always the same surgical technique. The angled fan tail itself, as the word says angled, it's angled for about 30 degrees. That angulation confines very well with the local anatomical area where you implant, the curvature of the skull. And when our implant surgeons are drilling an electrode lead channel, for example, that angled fan tail really sits very nicely then with the electrode lead in the channel. Moreover, we introduced for all flex series arrays with this implant a colored orientation marker, which also allows the surgeons to have a bit of a better view while they insert the electrode into the cochlea. And last but certainly not least, we also thinned out and shortened a little bit the electrode lead itself. And these are all feedbacks we got in the last years from our valued customers and surgeons to optimize the implants and even increase the usability tremendously. Now, a few slides on the MED-EL CI electrode arrays. You know that we designed our electrode arrays to provide superior hearing performance. And you might also know that we have three basic series of active arrays of electrodes: the classic series, the flex series, and the form series. And when you look now at this overview table, you see on the left side that we offer 5 different flex arrays with different length coming from the flex 20 up to flex 28 and then the flex soft. But we also have our classic line, which comprises of the standard, the medium, and the compressed electrode design. But also there is the form series with the form 24 and the form 19. And you can easily see now here that all these active arrays are slightly different in length and shape. And that means that they also have a different indication, of course, so for different cases. And this is what you might already know, the MED-EL philosophy behind it, because we very strongly believe that one size fits all is not a very good approach. It's like buying shoes, for example. You know, you buy the shoe in your ideal size, and there is no shoe one size fits all. So this is also very relevant, of course, for the cochlea. And today we will see the Flex 26, for example. And this is already the end of my quick overview of the implant and the electrodes, what we offer. And now I would like to ask Professor Löwenheim, are you here?
Yes, hello.
Yes, would you please show us your case today?
Yes, thank you for the introduction, and so let's get right into the case. We first show here the audiogram. The patient is a 33-year-old female patient. And as you can see with the audiogram, it's an asymmetric hearing loss with a profound hearing loss on the right side and normal hearing on the left side. The hearing loss on the right side has been progressive since 5 years and occurred after a measles infection. And we also can see this residual hearing loss in the left corner. We move on to the next slide, which is the CT. So if you can see the cursor here on the left side, we see a prominent sigmoid sinus. Otherwise, the mastoid is well pneumatized, and we see here the ossicles, the typical cone of ice cone formation here with the incus and the malleus head, the internal auditory canal, the cochlea, and here the vestibule, all very well pneumatized. So the other thing that if you go through the slides that you can see in this particular case, that the round window niche is relatively small, which may make the surgery later on a little more difficult. Also, of course, the prominent sigmoid sinus will sort of narrow down the view a little bit towards the axis in the facial recess. So what we routinely do then is also measure the size of the cochlea in order to select one of our electrodes from the electrode array portfolio that, for example, that MED-EL offers. And we do length measurements either in total, or we use the A value, which you can see here. That's from the middle of the round window to the opposite side of the cochlea. And in this case, we had 9.2 millimeter A value. That corresponds to about 32 millimeters in cochlear length. And then we can use the Autoplan software to get an idea what electrode we should select. So if we would go for a full coverage in length, and if we choose here the organ of Corti as the total length measurement, then we would best use a flex soft electrode that has 31.5 millimeter in length, as you know. But this can be, of course, difficult to insert, especially the apical turn can be very narrow, so not taking up this last bit of the electrode. And that would imply that we would actually lose two of the contacts. We couldn't insert them further on here. And also it has been shown that we have the best results with about 75% coverage. So in order to include both ideas, 75% coverage, hearing preservation and full insertion at the same time, the best choice in that case comes out as the 26 millimeter electrode, so the Flex 26 seem to be well suited for that case, and that's actually what we selected for the patients, and we talked about that with the patients before the surgery, and she agreed to this electrode length. I want to mention also that you can see the full video that is going to follow in the MED-EL video library with all the comments on there, just for you to review after this session. So now we move on to the actual surgical video. If there are any questions for the case, please don't hesitate to put that in the chat, and I'll try to answer them as I'm showing you the surgical video. Okay, so we start. So we have already done the retroauricular incision, and we are now preparing the periostal flap, we also create a periostal pocket to take up the implant later on. We use a 45-degree angle to place the implant against the linea temporalis. And as you can see here, this is the silicone dummy for the SYNCHRONY 2 with the central electrode lead exit, which at the time when it was introduced was, of course, you know, the previous model had the exit on the side, which was a little cumbersome sometimes because they had to do different surgeries for left and right. But with this central lead exit, this is now standardized for each side. So first, of course, the first steps in the cochlear implant surgery, as you know, there's 5 major steps: mastodectomy, posterior tympanotomy, exposure of the round window niche, and then the drilling the implant bed. And 5, of course, the last step is implantation itself. So we start off with number 1 here, the mastodectomy. We start to create a triangle by the linea temporalis, the Henle spine, and the cribriform plate. Remove the cortical bone and enter our way down into the mastoid. We switch over from the cutting burr to the diamond burr, and approach the corner septum. Make sure that we're not, that we keep the dura in the middle fossa and posterior fossa covered with bone. And we thin the posterior wall of the external auditory canal, to keeping in mind that we want to create the facial recess later on. So now we're drilling down into a corner septum, and we are entering the antrum. Our goal in the antrum is, of course, to carefully dissect down to see the landmarks there, which is the lateral semicircular canal, which is just coming up at this time. And as a second landmark, the short process of the incus. And we're still thinning out the posterior wall, approaching towards the antrum, carefully identifying the incus, which is coming up here. Now, of course, we have to be very careful with the drilling not to touch the incus, especially, of course, in case of patients with residual hearing, as we have it in this case also. So we expose further, take away some of the remnants here of the tissue, and then move on to the next step, the posterior tympanotomy. We also use routinely facial nerve monitoring, and as you can see in the video, first thing once we enter into that step is we control for the tympanic segment of the facial nerve as a positive control with our stimulator, and then we use a landmark not to injure the facial nerve, which is a line that we draw vertically through the short process of the incus, and we try to stay anterior to that line. And you can see that quite nicely, that if you look at that line, now we test again for the mastoid segment of the facial nerve. And if you look at the video later on, you can hear the sound of the stimulator, which is monitoring the response. So we already did have a response at this stage of the surgery. We continuously drill down. It's about a 2 millimeter space. Of course, anteriorly, we're now looking at the coda tympani already. We try to identify that, and we carefully thin out the bone towards the mastoid segment of the facial nerve. We also keep intact the bony buttress that holds the short process of the incus. That's an important structure to preserve for attaching the fixation clip later on, which I'm going to show you in a separate step. We now starting to enter the middle ear, and you can already see the mucosa bleed a little bit, and so that's the first sign that we are starting to enter. Continuously controlling for the facial nerve while we drill down there. Here again, the positive control in the tympanic segment. And yeah, we are still anteriorly to that line through the long process of the incus as you draw down vertically, not to injure the facial nerve. If you can see that my cursor on the screen, so this is this line, and we keep anterior to this line, and the facial nerve is just to the back of it. So if we stay in this anatomic area here, we are pretty safe in terms of preserving the facial nerve. So now we are approaching the round window niche. As I told you, in this case, the round window niche is very small. So we're going to have some difficulty to identifying it. So that also implies that I really have to maximize the size of the posterior tympanotomy. That's why it's so important that I exactly know where the facial nerve is. And here you can see I'm also identifying the tendon of the stapedius muscle, which is another good landmark. So if I'm staying anterior to that tendon, I'm also preserving the facial nerve here, okay? So having identified here the tendon, I'm already now drilling drilling the part of the cochlea of the promontory. There's this small bony overhang that obstructs the direct view to the round window membrane. And I'm using a very small drill to take down that bony overhang in order to expose the round window membrane directly. And in that case, as I told you, the bony overhang was really strong, and this is just a very small round window comparatively. But now you can already identify it, see it. It's that small gray structure down here. And it's particularly difficult to take away the posterior aspect of that bony overhang. Sometimes you have to drill away a little bit more of the posterior wall in order to have access with your drill. So here's the round window membrane. Is now, I think, sufficiently exposed for later insertion. So we're taking away some remnants of mucosa with that little instrument here. It's a 0.6 millimeter hook, which looks like a small knife. It's very useful to work with that hook. So as a special insert, I show you the fixation of the clip. For that, we have to prepare the bony buttress of the long process of the incus, and have to make sure that it's in shape to take up the fixation, the bony part of the fixation clip. And of course, again, you have to be careful not to injure the facial nerve in that maneuver, but if you keep abreast your landmarks, this is not a problem. So I'm thinning it down to a certain size to take up the clip. So once we've achieved that, as you know, the fixation clip has two sides of it to it. One is the fixation clip to take up the electrode, and the other part is the fixation clip to take up the bony buttress. And we're going to start out to fix the larger bony buttress clip here to the buttress. And I'm actually doing it this way, and we're going to stop the video for a while, so I have a little more time to explain you that. So I've already fixed this part of the clip to the bone, and here you can see the clip for the electrode. And I deliberately insert the clip with the electrode part up. Usually later it comes down here, but for the insertion I use it that way. And then I will flip around the clip 180 degrees, and that will give me the opening towards the surgical side, and then I can close it there. In the surgical manual, as you find it by MED-EL, it's done the other way around. So the insertion is done with the electrode side downwards, and the clip is closed with the clip ends towards the middle ear, and that's really difficult to handle, and sometimes you can't really close it that way. Yeah, so I prefer to do it this way. So keep in mind you have the opening of the electrode side here upwards, and then see what is going to happen in the next steps. So now we flip it around 180 degrees. Okay, and then you can see the clip fits nicely here into the facial recess. And I have full access here with the Hartmann forceps to close the bony buttress side of the clip. Okay, so then it's already fixed. And now I flip it back again to allow my surgery to proceed and to insert the electrode. So that's also something I do before the insertion. So I already fix the clip at this stage of the surgery. Then I fill up the middle ear with a solution of dexamethasone and hyaluronic acid. And then I close it with gel foam to protect the middle ear from bone dust that may now be produced while creating the implant bed. And this is the end of the round window exposure and posterior tympanotomy part of the surgery. So this is the gel foam, just to protect the middle ear from bone dust entering. And we also use the dexamethasone solution for photoprotective purposes. Now, step number 4 is preparation of the implant bed and the electrode channel. So this is maybe another interesting thing that I used to do, a kind of personal aspect, in order to orientate myself later on while drilling the implant bed. I create marks for this for the size of the dummy, and I do that without watering, and then I take out the dummy, and then I have my labels here, and so I know the extension of the housing of the cochlear implant. And yeah, depending on the case, I use cutting burrs, or in this case, I use a cutting burr. In adults and in children, I usually use diamond burrs, not to injure the dura. So once the implant bed is created, and I try to make sure that I have good margins, and that they are strong, that they are holding the implant in place later on. Then we have to create the electrode tunnel. So now with the SYNCHRONY 2 and the central electrode lead axis, we can do that in the sinodural angle. In this part of the temporal bone, the bone is relatively thick, and it allows you to create these tunnels. Of course, you have to keep in mind that the sigmoid sinus may come up, so you have to make sure that you're not injuring the sigmoid sinus or the dura. But you can check this in the CT preoperatively. Usually, this is relatively thick bone, 3 to 4 millimeters, or even more, to allow you to create an electrode tunnel that will help to fix and at the same time protect the electrode lead. Yeah. So we come from 2 sides, one from the implant bed side and one from the mastoid side, to create the tunnel. Yeah, so once that is achieved, we're actually ready to go for the actual implantation. We may create a small bony overhang to take up the electrode lead later on when we place the electrode in the mastoid, and we can do a check whether the silicone dummy fits well, and that seems to be the case. So we are ready for the implantation. We make sure to remove all the bone dust, and also now at this point in time we remove the gel foam that has protected the middle ear from bone dust entering. Now we actually place the implant if we created a deep enough periostal pocket, this is very easy. And then I slide the implant a little bit downwards, as you can see here, to allow the atraumatic placement of the electrode lead. Once again, I would like to point out that we have this colored orientation marker that was actually first introduced with the Flex 26, and then as the SYNCHRONY 2 was introduced, went over to all the other electrode lengths, and but this was the original. So here we place the electrode in the tunnel. Of course, you have to make sure that you're not traumatizing the electrode lead. So we do that very carefully, very slowly. Then we slide in the implant back into the implant bed, and we also make sure that the angled fantail, as was pointed out, is now placed securely in the electrode tunnel. Okay, so implant is placed, and we are now back in the mastoid. We do some further irrigation to remove any remnants of bone dust or other tissue before we open up the inner ear, before we actually make our incision into the round window membrane. Okay, now the next step is round window opening. As I told you, our visualization, because of the small round window at this case, is not ideal. I use a 45-degree angled hook to open up the round window. Usually I only make a small incision. Because this membrane was so small, the membrane came off completely. But if you do that in an atraumatic fashion, it's not necessarily contradictory to hearing preservation. And now I insert the electrode, and I use the colored orientation marker to be sure that the orientation of the electrode contacts is towards the modiolus while inserting the electrode. Before the marker, you can see the marker is now really out of focus here, yeah, but still I can see it, you know, and it helps me to orientate there. Before it was not labeled with a color, and then you could not see where the marker was. And now I think that's very helpful if you can see that here to orientate yourself. So we do that as slow as possible to ensure an atraumatic either hearing preservation type or structure preservation type insertion. That's our standard. We always do the atraumatic round window access, regardless of the hearing status, and of course it ensures either hearing preservation or structure preservation. So the electrode slides in, as I said, relatively slow. We even cut some parts out of the video. And now the marker is even better visible, okay? And it still has the upwards orientation. That's exactly where it should be, okay? Towards the modiolus. And then we make sure that the electrode contacts also come out in the right position within the cochlea, okay? So we now have to fix the electrode in order to take out the forceps and push the last bits of the electrode in there. Okay. So then we use a small piece of tissue to seal off the round window niche. And then later on, fix the electrode with the fixation clip. So I think it's well placed. We have control here, the colored orientation marker, and comes out really nice, exactly in the right position, a little upwards and towards the modulus. So now sealing off the round window with a small fibrous tissue or muscle tissue that we take from the temporalis muscle. We use an angled tip here. First place it under the electrode and then another tissue above. And that suits well. Now the fixation clip. So you just have to rotate it down now because you already did the work before. And then just gently slide in the electrode into the electrode fixation clip, close it off, and done. Okay, so that way you really make sure the electrode is nicely fixed. That's why I say it's really important that you place the fixation clip before you insert the electrode. Okay, so that way you ensure that you do not have to manipulate on the electrode anymore. So after that, you can once you have fixed that here, you can really nicely place the rest of the electrode in the mastoid and make sure that everything is nicely fixed and stays in the position where you want to keep it. Okay, so I think we've shown you the most important parts here. Wound closure. Of course, we make sure that we reconnect the three tissue layers. We start off with the periostal flap that I showed you in the beginning. And then we do subcutaneous sutures. And then we also close off the skin. Usually I use Dermabond, that's a skin glue. So we have no external sutures. It's especially helpful with children because you don't have to remove any sutures later on. So if there are any questions, I think we're ready to go for the discussion. So that's the Dermabond. Skin glue. And there we are. There we go. Thank you very much for your attention. And as I told you, if you like, there is a much more in detail version of this video available at the MED-EL video library, showing you the case and all of the surgical steps in detail with comments.
Good. So thank you very much, Professor Löwenheim. That was very interesting, and more interesting that you have live narrated this video for us. Of course, now to all participants, please type in either your question if you have some questions, or unmute yourself. So you are also, of course, very welcome to ask your question live, and so that we can hear you very well. Also, I've seen that in the direct chat, as the direct chat to the moderator, there were some questions already, but maybe you type them in again, either in the general chat, or just unmute yourself if you would please so. Maybe also raise your hand also that we can see. Otherwise, I will continue with the, yeah. Ah, yeah. So
okay, some compliments there.
yeah, Ned was asking here the name of the skin glue, what you have used in the
It's called Dermabond.
Dermabond. Okay.
Yeah.
Yeah.
Okay. Yeah.
Excellent. Yeah. So let's have a look at maybe at the direct chat. What we got in. Ah, okay. What was that? Okay. The question was, what's your opinion on measuring the skin flap thickness? In case you are under the impression that the skin flap is very thick, do you usually thin it out, or what would you suggest?
No, actually, I never do that, to be honest, and it has not been necessary. You know, of course, there may be extreme cases, yeah, but in general, it's not necessary, and it's usually well compensated with different degrees of the magnet. Yeah, okay. So I don't think you have to really worry about that in a normal case. Okay, there may be a very adipose patient with a very thick skin, but at least in our patient population, I've not come across a case like that. And so there was never the necessity to really thin anything out. Yeah. And of course, we then adjust the strength of the magnet, and that may vary, of course. Of course, in children it's relatively thin. Sometimes in women it's thinner. Yeah, and in men it may be somewhat thicker. That's something you have to think about. But in general, it's not a major concern.
Not a major concern. Just what out of this question, actually, what would interest me now is, could you actually also effectively measure the skin flap thickness, or not effectively maybe, but estimate the skin flap thickness with the hands of the CT scan? Would that be possible if you would have covered that region?
Yeah,
that you would
yeah,
measure
of course.
it, no?
Yeah, of course. You can use the coronal for example, or the axial view. To look at this, the thickness of the skin, and yeah, I mean, if it would exceed 5 millimeter, approach 8 to 10 millimeter, I would be concerned. But as I say, I haven't seen that.
Good.
Yeah. Okay.
There is a bit more now coming in the chat here, in the overall chat. So M. Peach says thank you. Yeah, to the skin flap question. There is the new S-vector magnet out. Yeah, thanks, of course, for that. We have also now released the SYNCHRONY 2 with the S-vector magnet. That's a new magnet development, diametric magnet development with an increased magnetic attraction force. Yeah, of about roughly plus 25%.
Yeah. That's something I really challenged MED-EL about when I was in Oldenburg already. You're nodding. You know, I always ask my technicians, you have to talk to them. The magnet has to be stronger, especially in the intraoperative situation. You know, we surgeons, we are kind of stressed in terms of time. Yeah. So every little piece of time is important, and usually while we do the intraoperative measurement, we already suture the patient, yeah, so that, you know, gains time for us. And we cannot do that if the magnet is not strong enough, because I have then to use my left hand to keep the magnet in place while the measurement is going on. And of course, I want to do a good measurement and want to measure all the 12 electrode contacts, and maybe repeat that and really be sure. And now with the stronger magnet, that's in most of the patients, you know, I can do that now in parallel, and, you know, suture off my periostal flap, or start doing this subcutaneous suture while I'm talking to the technician and looking at the screen how the measurements are coming off. Yeah. So that's really helpful intraoperatively, but of course also we have more variability now, and in the post-operative situation. Yeah.
Yeah, there is because you mentioned telemetry, Peter Ruev was actually asking a time of telemetry. I think he means how much time you take, or maybe it was meant to when do you perform the telemetry?
Yeah, as I said, right after, finishing off with the fixation of the electrode, before we start suturing off, we do the telemetry. We also control in the beginning, before we insert the implant. I would recommend that. In the past, we haven't always done it, but we're increasingly doing it to check whether there's any technical problem with the implant before we even touch the patient. Yeah, and so of course in most of the cases everything is okay, but we have checked that, and then we do the telemetry after the fixation clip, and usually I use the time to suture off already. Yeah, so it gives me maybe 5 to 10 minutes. That's about the measuring time that we need to shorten the surgery. Yeah.
Of course, I would like to add that this is a very tough situation for every implant holding magnet. When you just finished up the surgery, the skin flap might already be a bit swollen. Then you have the surgical draping also on top of it.
Yeah, so, I know. But it is. Yeah. It is certainly challenging, but it's very helpful that it's a little stronger now, and that we can use it despite the draping. Yeah. Yes. So okay.
Dear Kardik actually is very impressed about the development with the clip and the sealing with tissue. So maybe you can elaborate a bit more on your very impressive and it looks very easy, your clip technique, and actually very logic, so that you attach it first. Before you actually open the cochlea and then insert the active array, and then you really turn it into the right direction.
Yes.
So, do you always use the metal clip, or are there situations where you refraining of using it, or?
Yeah, no, I had one case more than 8 years ago where I didn't use it. And then a few days later, it turned out that it came out a little bit. So there were I saw it then in the post-operative image. Yeah. So you always have this learning case in your career or lifetime. And since then, 100%, I've always used the clip. I mean, there may be situations where I cannot use it in terms of a pre-operated ear, but I always use the clip. Yeah. So I don't want to go back to the patient and tell him, "Oh, I'm sorry, but your electrode seems to have slided out a little bit, and I have to go back to surgery with you." So I don't want to experience that again, and that's why I always do it. And it's worked quite well, and it's an easy procedure. We've tried to optimize a little bit. I think that makes the clipping of the bony part of the clip a lot easier, because you have direct access, and also you can flip it out of the way while you're inserting the electrode. It doesn't hurt you at all with your electrode insertion procedure. And then once you have inserted your electrode, you can just do the 180-degree flip back, and you're done. Yeah.
Very cool.
Yeah.
We also got another question regarding the choice of electrode length. For pure electrical stimulation. You said you always choose the length of 75% of the
that's an orientation. Yeah, that's an orientation. Actually, comes out of data from Hanover.
Stefan Volkenstein was asking you that question. So is that, do you always use that formula, or?
Yeah, I mean that's based on data from Hanover. They measure the functional outcome and different insertion depths, and according to their data, it seems that the 75 would be an ideal length. I know that there are other opinions that you might want to go to the 90 or 100% insertion, but really the question is, you know, is the apex of the cochlea really accessible? I mean, if the tip of the electrode, I mean, it has a certain diameter. Of course, the metal electrode is very thin at the tip and very fine, but really there is an anatomical limit, yeah. And I think it makes sense to have that 75 or 80% idea back in your mind, and that's kind of the length that you should adapt your electrode to, in terms of what we would call a full insertion. Okay. And then you shorten, of course, the electrode depending on your audiogram in EAS cases, in electroacoustic cases. There, of course, you know, depending on the residual hearing, you would use the 1 kilohertz frequency map to have your electrode go to that point. Yeah. And that could mean a shorter electrode and maybe only a 60% coverage in that case. Yeah.
We have also, to that very point, a question from Antonio Dumitru. He was referring more to the Flex 26. He says the Flex 26 and the Flex 24, they have the same active stimulation area or active stimulation range. Yeah, so they share actually the same electrode contact distance, one after the other. And the 2 millimeter more is more or less based on the basal part of the active array for the Flex 26. Yeah. So he was asking, when do you think is the Flex 26 then most suitable? When is it most suitable? Why did you choose then more often maybe the Flex 26?
Yeah, I mean, if you look at the Gauss curve for the distribution of cochlear length, then it starts off the total length maybe 24 millimeters, and the longest is 40 millimeters. So that's a lot of shoe sizes out there. Yeah, if you think about it in 1 millimeter steps, maybe. Yeah, so actually the peak of the curve is sort of right between 28 and 26. So that's why I think, you know, there is a relatively large group of patients that deserves the 26 electrode. I know by habit, the 28 has become the new standard after the 31, right? And there is, of course, this historic idea that in an EAS case, you go to a 24. But I think, you know, we are now one step ahead of that category. We should really individualize, yeah? And we can use the 26 in cases where we want to have a large coverage as much as possible, maybe in a relatively short cochlea or a mid-sized cochlea, I would say. I mean, 32 millimeter cochlea is a mid-sized cochlea, and a 26 electrode fits very well into that concept if you think about the 75 coverage. And if you have, let's say, a long cochlea, 38 millimeter, and but it's an EAS case, and you want to preserve the low frequency hearing, then the 26 might fit as well. Yeah. So there's you know, broad range of applications, and we should, you know, come away from the 4 millimeter shoe size difference to the 2 millimeter shoe size difference. Okay.
Yeah, thank
so
you very
really,
much. Maybe we have time for one more question now, because we have only a few minutes left of broadcast. So Theodoros Katsupopoulos has a question to you. So how do you estimate the size of the buttress.
Yeah. Well, also to be honest, it's kind of surgical experience, but to give you an orientation, it's about 1.5 millimeter, and that's the drill that I use in that instance, and it's about that size, and the fixation clip, the bone fixation clip fits well around that size. I mean, you can sometimes, of course, you can't drill the middle ear side of the buttress. I mean, there's this circumference of maybe 270 degrees that we can access through the mastoid. And sometimes, you have to use a little hook maybe to take away a small bony overhang to really make it a circle. Make it a full circle, or take away some mucosa that may obstruct the insertion of the clip. Those are situations that may occur on a case-by-case basis. But I think that's the size. I think what you have to care more about, that you're not making it too thin, and while you're drilling your posterior tympanotomy, you're thinking about other things, maybe the facial nerve, and that's actually what you should think about. But keep in mind, just preserve the buttress. And what happens in most cases is that the buttress is already gone, and then you have nothing to fix to.
Yeah, very well. I think we have reached the end of the questions. So thank you very much, Professor Löwenheim, for that very impressive surgery and your comments and the surgical pearls and pitfalls, what you shared with us today. So thanks a lot. I would now like to close this session, and also with the announcement of our upcoming Surgery Online, which is planned at May 12th. Around the same time again, Central European time, from 3 to 4 p.m. And it will go more into detail of the implantation of the active middle ear implant Vibrant Sound Bridge. So I hope you join us again here. And I would also like to say that we are going to send out in roughly about a week the recording of this session to all participants, so you can rewatch that, or even better also, to what Professor Löwenheim said, go to the ARI video library, the MEDEL video library, and register there. And also you can watch there his implantation of the SYNCHRONY 2 with the Flex 26 in a bit more detail. So thanks for participating for our first Surgery Online hybrid live event, and thanks for watching, thanks for having us, and goodbye until the next time.
Thank you also.
Bye-bye.
Bye-bye.